I'll start the session off with a talk on systemic therapy for esophagus cancer. Because of the time constraints, the material I'm presenting is highly selected and unfortunately maybe too cursory, but we'll try to go through as much as we can. This is Humphrey Bogart. Many of you will recognize him. He died of esophagus cancer at age 58. The photograph shows you one of the reasons why. He was also a very heavy, known to be a very heavy alcohol user. My objectives are to discuss the changing epidemiology and biology of esophagus cancer, present some selected treatment advances, and review information on biomarkers. The latter topic will be relatively brief for reasons I'll explain. Esophagus cancer really is two diseases, at least two diseases. Squamous cell carcinoma and adenocarcinoma have distinct biologies. For squamous cell carcinoma, most of them occur above the GE junction. In the U.S., they're strongly associated with tobacco and alcohol use. In the U.S., the highest prevalence is in African Americans, and this is even when you adjust for tobacco and alcohol use, that high prevalence still persists. Worldwide, there's a universal association with poor nutrition and dentition, and as with other squamous cell carcinomas, death is usually from local disease. It's mainly a problem of local disease. Adenocarcinomas, in contrast, involve largely the lower third of the esophagus, and as you know, there's a strong association with obesity, GERD, and especially Barrett's esophagus. The highest prevalence in the U.S. is in white males, and the incidence is rising at an astonishingly rapid rate. As with other adenocarcinomas, death is typically from metastatic disease. When I gave a talk on esophagus cancer in 1980, I hate to date myself, but I did have a pie graph that looked like the one on the left side of this slide. 90% of the esophagus cancers were squamous cells, so I would say a few words about adenocarcinoma and then spend the rest of the talk on squamous cell carcinoma. If you give a talk on esophagus cancer now, you need a pie graph that looks like the one on the right side of the graph. And this truly illustrates the remarkable rise in the incidence of adenocarcinoma of the esophagus. It's probably the fastest rising incidence of any cancer that we have these days. And now the discussion has to sort of center on in two places. Just for fun, I totaled the analytic cases from the last 5 years at our institution. We have a population that is about 75% African American, and we're in an urban population, so that we have very high rates of tobacco and alcohol use overall. And as you can see, squamous cells still slightly predominates at our facility, but not by much. Another problem with esophagus cancer is the changing definitions. If you look at the current AJCC manual, staging manual, it defines tumors centered within 5 centimeters of the gastric cardia and extending to the GE junction as esophagus cancers. If you look at the prior staging manual edition, 2002, it states that the issue is controversial and that cardiac tumors within 2 centimeters of the GE junction are gastric. If you look at earlier editions of the manual, it says nothing. Of course, this reflects the fact that the incidence of adenocarcinomas has risen so dramatically over this period of time, but it does create problems in interpreting the literature. Histologies vary among studies, and you have to pay attention to which patients are included. The anatomic sites vary, and of course this is also true for gastric studies. The defined anatomy has varied over time, and so you have to be very careful when evaluating the literature and comparing studies, particularly done at over disparate time periods. I'm now going to go through some selected landmark trials. The term landmark may be arguable in some cases, and the studies you would select may not be the same ones that I selected, but we can talk about that later if that's the case. The first study I wanted to refer to was the very well-known Herskovich trial from 1992, which was limited to patients with thoracic squamous cell cancer. It looked at 5FU cisplatinum with 5,000 centigrade radiation compared to 6,400 centigrade radiation alone. And the primary endpoint was overall survival. This trial was stopped early at an interim analysis when the median overall survival strongly favored the combined modality arm. The 24-month survival also was very strongly in favor of the combined modality arm, 38% versus 10%. This established chemoradiation as standard of care for locally advanced thoracic squamous cell esophagus cancer. The intergroup 0123 trial published in 2002 was for squamous cell carcinoma or adenocarcinoma. These were non-surgical cases, patients not eligible for surgery, and they compared cisplatinum and 5FU with either 64.8 gray or 50.4 gray radiation. Overall survival and local regional control were essentially the same in both arms, but there were more deaths in the high-dose arm, establishing 50.4 gray. That should say that there's a mistake on the slide. It says centigrade. That's obviously 50.4 gray as the standard radiation dose with concurrent 5FU and cisplatinum. The next trial I wanted to discuss was by Beden and others, JCO in 2007. This study asked a surgical question, specifically whether patients who received 2 cycles of 5FU and cisplatinum along with radiation would benefit from surgery or continued chemotherapy and radiation. The radiation dose, it's difficult to state because it allowed for different schedules, but the total radiation dose was 66 gray in patients who went all the way through on chemotherapy and radiation. The primary endpoint was 2-year overall survival, and basically the outcomes were the same. However, in terms of survival, 3-month mortality was 9.3% in the surgery arm versus about 1% in the chemotherapy radiation arm. It was noted that the local recurrence rate was lower in the surgery arm. So this suggests, the local recurrence rate was higher in the local recurrence rate was lower in the surgery arm. So it suggests that there was no overall survival benefit for surgery after chemo and radiation, but better local control. There was a smaller trial published in 2005 that looked at exactly the same, virtually the same design and showed exactly the same results. The POET trial, published in 2009, was a problematic trial. It was restricted to adenocarcinoma at the GE junction. These patients received 5-FU cisplatin with or without radiation therapy, both arms going to surgery following induction therapy. The primary endpoint was overall survival, and the trend was very strongly in favor of the combined, the trimodality arm. However, because the study accrued poorly and was closed early, the p-value was 0.07. So the purists among us would simply say this is a negative trial. There's a case to be made for that, but the trend was clearly very strongly in favor of trimodality arm. The CROSS trial. This trial was published in 2012, and also it was interesting in a few different ways. It took operable patients, squamous cell or adeno, including GE junction carcinomas. They were randomized to surgery alone or following paclitaxel and carboplatin, and radiation to 41.4 gray. Primary endpoint was overall survival. The overall survival was very strongly in favor of the trimodality arm. The R0 resection rate was 92% in the trimodality arm versus 69% in the other arm. The study confirms the value of pre-op chemo and radiation, and it also, to me, the interesting thing is that it showed the activity, at least, of a non-cisplatin containing regimen. Many of our patients, and maybe many of yours, are not eligible for cisplatin, particularly populations. We have, as I said, we have an African American population with high rates of hypertension, diabetes, and therefore renal disease. And it's difficult to give cisplatin to a lot of patients. So while this study didn't specifically ask a question, a comparative question about these regimens, it's pretty clear that this regimen was active in adenocarcinoma of the GE junction. I would also make reference to I didn't make a slide for this, but the Prodigy trial, which was just recently published, looked at FOLFOX versus 5-FU and cisplatin and found that they were equivalent in adenocarcinoma of the esophagus. So it does show, the literature does show that there are non-cisplatin regimens that can be used in these patients. I'm going to talk a little about trastuzumab, and my objective regarding biomarkers is going to be limited to this slide and the next one. A talk on biomarkers in esophagus cancer could be an hour long. There are hundreds of putative biomarkers. However, the only one that's really ready for prime time right now is HER2. And it's been recognized that about 15% of EG junction gastric carcinomas are HER2 positive. This is actually not far from the rate of positivity in breast cancer. The TOGA trial, I didn't put that trial up at the top because I'm not sure it's a landmark trial, but it was a pivotal trial that led to the approval of trastuzumab in gastric adenocarcinoma. Study of 5-FU and cisplatin plus or minus trastuzumab showed overall survival prolongation by 2.6 months. The only patients with IHC 2 and 3 plus tumors responded, and all patients had FISH testing for HER2. Patients who were FISH positive but IHC 0 or 1 did not respond in this study. The overall response rates, by the way, were 47 versus 35%. The other thing that's important, or at least important to raise, is the fact that the criteria for IHC positivity may differ from those for breast cancer. In fact, a modified set of criteria was used in the TOGA trial. And I'm not going to go into the details of these differences right now because they are controversial, but I think pathologists need to look at these, and you might want to know, if your pathologists are looking at this in-house, what set of criteria they're using, and whether they feel that the standard ASCO and CAP criteria, which are still in effect, are used, or whether the modified criteria are in use. Ramucirumab is a VEGF2 inhibitor. It's known that increased levels of VEGF worsen prognosis. So VEGF2 could be considered a prognostic biomarker in esophagus cancer, but I will say plainly that this is not used in routine clinical practice, and I'm not sure it should be recommended as such. But that is the other biomarker of relevance right now. The VEGF2 inhibition prolonged survival in animal models, and recently a pivotal trial called the REGARD trial looked at second-line ramucirumab alone or with chemotherapy and showed an improvement in overall survival of 1.5 to 2 months. Not earth-shaking, and certainly this is not as good as we want to see, but it's the first, along with trastuzumab, these are the first targeted agents that seem to have had an effect in adenocarcinoma of the esophagus. Whoops. Well, I lost my conclusion slide, but my conclusions obviously there they go, thank you. The changing biology and definitions require care in assessing clinical trials. I can't emphasize that enough. It's really something we have to look at when we're comparing trials. Some trials, though, have set new care standards, and some advances have demonstrated improved overall survival. Multimodality therapy seems to improve overall survival in esophagus cancer. The role of surgery is unclear, but we may get some clarification about that shortly. It does seem to improve local control. And finally, non-cisplatin-containing chemotherapy regimens are active, at least in adenocarcinoma of the esophagus. Some targeted agents modestly improve overall survival at this point. I'm going to stop there.